Ketamine functions primarily as a non-competitive antagonist of the N-methyl-D-aspartate receptor, binding within the ion channel pore when it is open. This action prevents the influx of calcium ions necessary for receptor activation, effectively silencing the NMDA receptor. The binding site is distinct from the glutamate binding site, classifying ketamine as a use-dependent blocker. This mechanism is crucial because it preferentially affects highly active neurons, offering a targeted modulation of neural circuits. Unlike traditional antidepressants that require weeks for efficacy, ketamine's effects on mood can manifest within hours, directly correlating with this immediate receptor blockade. The drug is highly lipophilic, allowing it to cross the blood-brain barrier rapidly, contributing to its fast onset of action. This initial blockade sets the stage for a cascade of downstream neuroplastic changes. Following intravenous administration, ketamine exhibits a rapid distribution phase, reaching peak plasma concentrations within minutes. Its half-life is relatively short, typically around 2 to 3 hours, necessitating controlled clinical settings for administration. Ketamine is metabolized extensively in the liver, primarily by cytochrome P450 enzymes, specifically CYP2B6 and CYP3A4. The main active metabolite is norketamine, which retains approximately 1/3 of the parent compound's potency as an NMDA antagonist. Norketamine contributes significantly to the sustained effects observed after the initial ketamine dose wears off. The rapid clearance profile minimizes prolonged systemic exposure, but the psychoactive effects require careful monitoring during the acute phase of treatment. Understanding this metabolic pathway is essential for predicting drug interactions and optimizing dosing regimens. The NMDA antagonism leads paradoxically to a massive surge in glutamate release in key brain regions, including the prefrontal cortex. This occurs because ketamine preferentially blocks NMDA receptors located on gamma-aminobutyric acid, or GABA, interneurons. GABA interneurons normally inhibit pyramidal neurons, which are the primary source of glutamate. By inhibiting the inhibitor, ketamine disinhibits the pyramidal neurons, resulting in a sudden, robust release of glutamate into the synaptic cleft. This transient increase in extracellular glutamate is the immediate trigger for the subsequent neuroplastic changes. This disinhibition mechanism explains why the therapeutic effect is not simply due to receptor blockade, but rather the resulting excitatory signal that follows. The glutamate surge activates postsynaptic alpha-amino 3-hydroxy-5-methyl-4-isoxyl-propionic acid, or AMPA, receptors. This activation is critical as it initiates the intracellular signaling cascade responsible for synaptic repair. Specifically, AMPA receptor stimulation leads to the activation of the mammalian target of rapamycin, or mTOR, signaling pathway. The mTOR pathway is a master regulator of protein synthesis and cellular growth. Activation of mTOR increases the translation of messenger RNA into proteins essential for synaptic structure and function. This pathway bypasses the slow genomic changes required by traditional antidepressants, explaining the rapid onset of ketamine's action. The integrity of the mTOR pathway is directly correlated with the efficacy of ketamine in preclinical models.
The activation of the mTOR pathway culminates in rapid synaptogenesis, the formation of new synaptic connections. Within hours of ketamine administration, there is a measurable increase in the density and function of dendritic spines, particularly in the prefrontal cortex and hippocampus. Dendritic spines are small protrusions on dendrites that receive synaptic input. Their loss is strongly implicated in the pathophysiology of major depressive disorder. Ketamine reverses this structural deficit by promoting the synthesis of synaptic proteins like postsynaptic density protein 95. This structural remodeling enhances communication between neurons, effectively restoring connectivity in circuits compromised by chronic stress or depression. The physical growth of these spines provides a tangible structural basis for the observed rapid clinical improvement. Ketamine and its derivatives are primarily utilized for treatment-resistant depression, defined as failure to respond adequately to 2 or more conventional antidepressant treatments. The rapid onset of action makes it particularly valuable for patients experiencing acute suicidal ideation, where immediate intervention is necessary. Dosing typically involves sub-anesthetic levels, often administered intravenously over 40 minutes to minimize dissociative effects while maximizing therapeutic benefit. Repeated administrations, usually twice weekly for several weeks, are often required to maintain the antidepressant response, as the initial effect can wane. The clinical protocol requires close monitoring due to the potential for transient increases in blood pressure and heart rate during infusion. The NMDA antagonism is also responsible for ketamine's characteristic dissociative and psychomimetic effects, which include feelings of detachment from one's body and environment. These effects are dose-dependent and typically peak during the infusion period. Other acute adverse effects include transient hypertension, tachycardia, and nausea. Chronic high-dose recreational use is associated with severe urological complications, known as ketamine-induced cystitis, and potential neurocognitive deficits. In clinical settings, the dissociative experience is managed by maintaining a controlled supportive environment and using lower sub-anesthetic doses. The balance between achieving therapeutic synaptic plasticity and managing the psychoactive profile is a central challenge in its clinical application. Ketamine is administered clinically as a racemic mixture containing equal parts of two enantiomers, esketamine and R-ketamine. Esketamine, marketed as Esketamine, has a significantly higher affinity for the NMDA receptor than R-ketamine, making it approximately 4 times more potent in receptor blockade. Esketamine is approved for clinical use as a nasal spray for treatment-resistant depression. Conversely, R-ketamine is currently under investigation and may possess superior sustained antidepressant effects and potentially fewer dissociative side effects, although its NMDA affinity is lower. The differential pharmacological profile suggests that the therapeutic benefits may involve mechanisms beyond simple NMDA antagonism, possibly related to the distinct downstream signaling pathways activated by each enantiomer. A significant limitation of ketamine therapy is the potential for tolerance development and the need for repeated dosing to sustain remission. The mechanisms underlying this tolerance are not fully understood, but may involve compensatory changes in AMPA receptor function or altered mTOR signaling over time. Current research focuses on identifying biomarkers that predict response to ketamine and developing novel compounds that mimic its rapid synaptogenic effects without the dissociative side effects. Investigating the role of brain-derived neurotrophic factor, or BDNF, and its interaction with the mTOR pathway remains a key area. Future pharmacological strategies aim to isolate the beneficial neuroplasticity while mitigating the risks associated with NMDA receptor blockade.